Hello, my name is Dr. Kimberly Cheatham, and welcome to a discussion of normal female reproductive cycles. Our objective is to discuss the physiology of the normal menstrual cycle. Normal female reproductive cycles include changes over time that occur simultaneously in the ovarian follicle, in the hypothalamus, which regulates basal body temperature, in the pituitary gland, which produces the gonadotropins FSH and LH, with the ovarian production of estrogen and progesterone, and in the endometrium. The average length of a reproductive cycle is 28 days, but can normally range from 21 to 35 days. The cycle is divided into three phases. Number 1, menstruation and the follicular phase. Number 2, ovulation. And number 3, the luteal phase. These three phases refer to the status of the ovary during the reproductive cycle. The first half of the cycle is the follicular phase and involves the growth of the follicle. The second half of the cycle is the luteal phase, named after the corpus luteum that forms after ovulation. It is the corpus luteum that produces progesterone and estrogen after ovulation occurs. In contrast, when referring to the endometrium, the phases of the menstrual cycle are termed the proliferative and secretory phases. During the proliferative phase, estrogen is produced in increasing quantities and leads to a proliferation of growth in the endometrium. After ovulation, the secretory phase occurs. Progesterone is produced that stabilizes endometrial growth and stimulates the secretion of chemicals into the uterus that allow for survival and implantation of a fertilized egg if there is one. This slide shows FSH and LH levels and their fluctuations during the menstrual cycle in the graph on the left. Note that a surge of LH and FSH occurs at mid-cycle. This surge is in response to high levels of estrogen. On the right, the levels of estrogen and progesterone are also shown over a menstrual cycle. Estrogen predominates in the first half of the cycle and increases over time until a threshold level is reached that triggers the LH surge. After the LH surge, ovulation occurs and the corpus luteum is formed. The corpus luteum produces estrogen and progesterone during the second half of the cycle. Progesterone effects predominate over estrogen effects during this time. Even though these two graphs are separate, note that the changes in gonadotropins and the changes in ovarian steroid hormones are occurring simultaneously in the cycle. Let's review each phase of the menstrual cycle, starting with the follicular phase. At the very end of the previous menstrual cycle, production of progesterone and estrogen drops dramatically from the degenerating corpus luteum. This drop in ovarian hormones leads to the onset of bleeding from sloughing of the endometrium. The decreasing levels of estrogen and progesterone also lead to a rise in GnRH secretion from the hypothalamus and a subsequent rise in pituitary gonadotropins at the beginning of the next follicular phase. The rise in FSH at the beginning of the new follicular phase stimulates the ovary to develop multiple follicles that produce estrogen. Rising estrogen production has a negative feedback effect on the hypothalamus and the pituitary, leading to a decrease in the secretion of FSH. Once estrogen levels rise past a certain threshold, estrogen begins to have a positive feedback effect on the pituitary instead of the previous negative feedback effect. This positive feedback effect from estrogen on the pituitary leads to an LH surge. 24 to 36 hours after the LH surge happens, ovulation occurs. This slide depicts the process of estrogen production in the ovarian follicle during the follicular phase. Ovarian follicles contain two important cell types, the theca cell located on the outside of the follicle and the granulosa cell located on the inside of the follicle. For estrogen production to occur, androgens are first made in the theca cells, stimulated by LH. These androgens diffuse over to the granulosa cells and are used as precursors in the creation of estrogen. Estrogen production from androgen precursors is stimulated by FSH. This process is known as the two-cell theory of estrogen production by the ovarian follicle. Now that the LH spike has occurred, it stimulates release of the egg from the follicle, a process known as ovulation. After ovulation occurs, the residual cells from the empty follicle become luteinized from the LH hormone and the corpus luteum is formed. At the time of ovulation, the egg is swept up into the fallopian tube. Fertilization must occur within 24 hours of ovulation or the egg degenerates. Fertilization usually occurs in the ampulla of the tube, and the zygote travels over several days to the uterus where implantation occurs. After ovulation, we enter the luteal phase of the menstrual cycle. The residual cells from the now empty ovarian follicle have responded to LH and form the corpus luteum. The corpus luteum produces estrogen and large amounts of progesterone. Progesterone acts on the endometrium by influencing it to become more glandular and secretory in preparation for implantation of a fertilized egg. If fertilization occurs, the outer layers of the pregnancy, referred to as the trophoblast, produce human chorionic gonadotropin, or HCG. HCG maintains the corpus luteum so that it can continue production of progesterone and estrogen during the first trimester of pregnancy. If fertilization does not occur, no HCG is produced and the corpus luteum degenerates. With loss of the corpus luteum, estrogen and progesterone levels fall precipitously. The withdrawal of estrogen, and especially progesterone, leads to the normal sloughing of endometrial tissue, which comprises the menses. With low levels of ovarian hormones, FSH levels begin to rise again and select the next cohort of follicles. You can see that the normal process of the menstrual cycle relies on the proper functioning of the hypothalamus, the pituitary, the ovaries, and the endometrium, and requires an open reproductive tract from the vagina to the cervix, the uterus, and the fallopian tubes. Any abnormalities along this axis, or any obstruction in the reproductive tract, will lead to abnormal menstrual function. When interviewing a female about her menstrual cycles, you can determine the presence of any abnormalities if her cycles do not fall within expected normal parameters. Normal menstrual function parameters include an interval of 21 to 35 days from the first day of menstrual bleeding in one cycle to the first day of menstrual bleeding in the next cycle. Bleeding duration should last between 3 and 7 days and should not result in anemia of the patient from heavy flow. Normal menstrual function occurs from an organized sequence and proper timing of endocrine signals. Endometrial sloughing of tissue is self-limited because the tissue is stabilized by exposure to progesterone, and the superficial layer of the endometrium is sloughed at the same time, leading to organized regeneration with the next cycle. This concludes the presentation on normal reproductive cycles.